are there specific guidelines you choose between how many surgeries you do and going to a bypass?
Specific guidelines? Sorry, I don't understand the question. Can you repeat, please?
Is there any sort of algorithm that you use where you say, well, endo is not going to work or endovascular is not going to work, so I am going to send them for a bypass? What is your threshold? And I would imagine it would depend on the area of the leg and the foot for that.
Now, honestly speaking, very transparent and honest, there is no space for surgery when endovascular fail. I mean, if the patient has a good option for surgery, a good endovascular surgeon is able to manage in the proper way the revascularization. If the patient fail with endovascular, is going to fail with the surgery too. You can believe me, 100% of my patients, of the 100% of my patient, maybe less than 5% could perform a bypass, but for sure, I'm able to do better by endo, less invasive, less complex for the patient, less comorbidities for the patients, less complications by endo compared to surgery. About the patients that I cannot manage by endo, normal endo, because still today we have DVA, deep vein arterializations, and so on, that procedures that allow us to increase the number of treated patients. All those patients that cannot be managed by endo cannot be managed by surgery, because when endo fail is because we are talking about heavy calcified small artery disease. So it means foot arteries heavily calcified that we cannot cross, we cannot open, and no any vascular surgeon can anastomose a bypass to this heavy calcified occluded foot arteries. So when endo fail, and open surgery fail too. When I send the patient for a vascular surgeon for a bypass, as I said, I can remember the last time I did, but when with good threshold could be a patient that you manage a FEMPOP revascularization, you did your DCB and it failed, you put your stent and it failed, you did atherectomy plus DCB in stent and it failed. Okay, maybe before to repeat multiple times, if the patient is a good candidate for surgery and he has or she has a good vein for a vein bypass, well, maybe it's good to, rather than to stay repeating and repeating and repeating endovascular, if you did a good job from the beginning by endovascular and it was not performing well, it's very honest and good option to send the patient for a vein bypass at the second or the third time.
Does that answer your question, Douglas? Yes. They try to send here, at least in the US, and also I know in England, they try to send patients that are on the younger end for bypass. But my question, because they claim it's more durable, and so I hear a lot of vascular surgeons say, well, I want to go ahead for the bypass because it's more durable. We can kick the can down further. But my response is, okay, so you kick the can down further for these younger patients or any patient whatsoever, and you say, okay, well, this bypass is going to last 7 to 10 years, maybe even 20, but if it's a younger patient, so they get to 20 years, what's next? Is amputation the only option for them after the bypass? What are the options beyond bypass? In some cases, yes, they can redo the bypass if by that point the vein is still healthy and they might be able to use synthetic as well. But a lot of patients always ask me, what are the indications, or when can an interventional doctor such as yourself go in and actually clear out a bypass graft?
Well, for sure, bypass, vein bypass is more durable compared to most of the endovascular approaches. What means young patient with good veins. Why vein bypass are more durable? Because it's done from healthy arteries to healthy arteries. This is not the situation with diabetic CLI patients. Diabetic CLI patients, they don't have healthy arteries. They
Yep.
have less disease or more diseased arteries, but all the arteries are diseased. So it's very difficult to have a durable vein bypass in a CLI patient because there are no healthy arteries. For example, bypass is fantastic for traumatic arterial disease. If you have an accident, you broke your leg, you damage your artery, the surgeon take the vein, put the bypass, it's going to be very durable. I saw 2 bypasses from femoral artery to dorsalis pedis, 15 years and 20 years, still patent, post-traumatic. So when you have a healthy arteries, bypass is fantastic, vein bypass. In our population, without healthy arteries, bypasses are not so durable as we have been discussing. For sure.
Yeah, because
For sure, a bypass is still an option. And a patient with a bypass failure after 10 years, 5 years, 3 years cannot be amputated because what was bypassed 3 years before, 5 years before, can be opened after 5 years. We managed to open the native arteries in most of the patients after surgery, doing crazy procedures, even with surgical ligation. We use re-enter devices from below, from above, and so on. We are very, how can I say, inventive guys, and we manage.
I love that.
We manage to open these arteries. So amputation is the last frontier, is the last option, is when we finish every option. And let's say that again, natural history of most CLI patient is to finally, at some step, finish with an amputation. But it doesn't mean to lose the leg, maybe a toe or a forefoot. But our mission is to help the patients as much as possible to avoid that as much as possible. Even if we know that finally most of the CLI patients at one step will need some surgical procedure in the foot and could lose some tissue of the foot, our idea is to do the best to avoid that, or to protect the patient from any amputation as long as possible. So being conscious that, as I said before, it's like to fight with the cancer. We are not going to heal the patient. We cannot remove the disease, but we must to help the patient to follow the patient in this long way of the CLI to avoid amputation as much as possible, or at least to delay as much as possible.